Good morning and welcome to Medical Grand Rounds. So today is our monthly department meeting and resident case conference. I just have a couple of things for the department meeting portion. Those of you who are clinicians in the department should have received a new set of department rules and regulations, and let me know if you see any concerns or issues with that. I do have one item on that people have pointed out to me is not reflective of current practice, so I have to go back and revise that. So if anything else shows up to people that sticks out, let me know. I mean, this change was a long time coming. It reflects our electronic medical record and the way we work with our electronic medical record, which really was not reflected in department rules. So very quickly, I wanted to review some COVID-related things that got brought up at a leader meeting earlier this week. This is the county webpage that many of you might be looking up. This is actually 1 day old. Yesterday's number was 144. So a little worrisome that till last week, numbers were coming down, and then between last week and this week, they've ticked back up very slightly. So hopefully that's just noise, but we're keeping a close eye on it. Same thing with the inpatient census. You see this big wave and then this little bump in the last week. Honing down on a 30-day trend, we got as low as 69 hospitalized patients for the system, but then in the past week have crept back up to 90. These are the nursing home census numbers, and this pink block that's increased here represents the special nursing home facility that the system opened to facilitate discharges. And ventilator dependence, as you can see, this is a tail that seems to go out. There's still several people in the ICU that are sort of stuck on ventilator support, sometimes for prolonged periods of time. I wanted to bring this one to people's attention. So this FEMA vaccination site, which the hospital is helping support, opens next week. And I think registration for this is already open. So you can direct your patients towards this. This is the website over here. And vaccination will start March 3rd at this 1447 St. Paul Street site. They're planning to do 1,000 vaccinations a day for the next month. So the first week, the people who are eligible are ones who live in these 12 zip codes. So the idea is to get people who are so far underserved and underrepresented in the vaccinated population. So if you have patients who live in these zip codes, they will be eligible for these vaccination sites if they're otherwise eligible for New York State vaccination. And then the other thing I wanted to point out was that our toolkit on the intranet has now added this table of agents that are not recommended for COVID infection at this point. We've had some requests from patients and families for things like ivermectin. This was in the newspaper. And ozone was a more recent request. So they've done a very good job with creating this list that the institution does not recommend. This is in addition to a couple of tables that include recommended treatments for COVID-19 infection. So I just wanted to point those things out before we plunge into our case conference, so I will stop sharing at this point. And
thank you so much, Dr. Phatak, and good morning, everyone, for tuning in. My name is Zeni Kharel, and I'm one of the second-year internal medicine residents. And I'm presenting this case titled Prelude to PNH with Dr. Sbenghe. And the reason for my title would be clearer as we near the end of my presentation. So a 45-year-old Hispanic male presented to the ED after noticing one episode of bright red blood per rectum, 1 day prior to presentation, and diarrhea ongoing for the past few weeks. So he had a single episode of bright red blood per rectum 1 day prior to coming to the hospital. And he had been having some watery diarrhea for the past 3 weeks, but no other abdominal symptoms, including pain, nausea, or vomiting. And he did not endorse any fever, chills, weight loss, or any other red flags concerning for any malignant process. So past medical history, he has a history of external hemorrhoids ongoing for about 2 years now. Past surgical history, he has a history of partial colectomy after a motor vehicle accident that was followed by colostomy and eventually followed by reversal of the colostomy. And this was a long while back in the 1990s. And his family history is significant for some diabetes and hypertension in his parents. Social history, he's been smoking about half pack a day for about 2 decades. He used to be a prior heavy drinker. How much he drank is unclear from the chart, but currently he drinks about 1 to 2 beers occasionally on weekend since the past 1.5 years. And there was no mention of alcohol withdrawal. He denies any IV drug abuse. He is a very active person at baseline and juggles 2 jobs. And he moved to Rochester from Puerto Rico in 1994. Medications, he's just on some thiamine, folic acid, and nicotine patch, and no known drug allergies. So when he presented to the ED, he was found to be febrile, though that was not his subjective symptom. So it was almost discovered incidentally. And he was also found to be mildly tachycardic. And the rest of the abdominal exam was normal, apart from the vestiges of his prior abdominal surgery. His bowel sounds were hyperactive. That goes with diarrhea. No organomegaly was seen, and rectal exam noted some external hemorrhoids. Other than that, his physical exam was normal. So these are the lab findings from admission. So the abnormal values have been marked in red. So his CBC was remarkable for some pancytopenia, though it looks like he had some pancytopenia before. And these labs are from about 18 months ago. Curiously, his urinalysis showed small amount of blood and no RBC. And his CMP was remarkable for some bilirubin elevation, 3.7, but the bilirubin was not fractionated, and some mild transaminitis, some elevation in ALP, some mild elevation in INR. And all of these labs were unremarkable in his last check. So we got a CT abdomen because he was febrile and having some abdominal symptoms. And the CT showed a large heterogeneous liver mass, about 15 by 10 by 8 centimeter in his liver. It also did not show any portal vein, so raising concern for some portal vein thrombosis. And it also showed some edema in his ascending colon. So in this slide, we can see some bowel wall thickening and some fat stranding near the affected part of the bowel. So he was started on piperacillin tazobactam, Zosyn, for presumed colitis. Our gastroenterology team was consulted for possible liver cancer due to the finding that was seen in the CT scan. And our GI team recommended getting an MRI to further look at the hepatic mass and checking AFP due to concerns for hepatocellular cancer. And for his bright red bleeding per rectum, conservative management was done. So as recommended by GI, MRI was obtained on the second day of admission, and it showed the same big liver mass as was seen in the CT scan. It showed some mild splenomegaly, and it showed some abnormal density in the renal cortex. So day 2 of hospitalization, antibiotics were continued for his colitis, and interventional radiology was consulted for liver biopsy. Day 3, the liver biopsy was done by IR, and antibiotics were de-escalated to augmentin. And on day 4, he was good to go. So he was discharged home on augmentin, and he was asked to follow up his biopsy and tumor marker results as an outpatient. And he was given a surgery referral for the hepatic mass. So 3 weeks after discharge, he consulted surgery as an outpatient. The AFP that was done in the hospital returned back normal. And the CT and the MRI findings were thought to be inconsistent with hepatocellular cancer. And the core needle biopsy that was done in the hospital showed some focal sinusoidal dilation, but curiously, no evidence of fibrosis or hepatitis. So almost out of disbelief, all the labs were repeated. He was tested for more tumor markers, including CEA, CA19-9, and chromogranin. And he was asked to repeat the ultrasound of the liver, to repeat the biopsy of the liver. So he got the labs as requested. And the CBC still shows pancytopenia, which is persistent. The CMP still looks about the same, maybe slight decrease in total bilirubin. But this time we do have the fractionation of the bilirubin, and it was a predominantly indirect bilirubin. He continues to have mild transaminitis. His ALP is still elevated. His INR is still slightly up. And the core needle biopsy, the repeat core needle biopsy, showed similar findings as before, with some thrombi within the central vein, which was a new finding from his prior biopsy. So he followed up again with surgery 7 weeks after discharge. So after taking all the lab values and imaging studies into consideration, neoplasm was thought to be unlikely. So given the finding of the hepatic venous thrombosis on the biopsy, he was advised abdominal ultrasound with Doppler studies. And he was referred to gastroenterology for liver disease of uncertain etiology. And he was also referred to hematology due to possibility of Budd-Chiari syndrome due to the visualization of thrombi in the central veins of his liver in the biopsy. So he got the abdominal ultrasound with Doppler, and it showed that the portal veins are narrowed, meaning maybe there is some underlying thrombosis. The liver still looked very big, and it had the signal was abnormal. It had an abnormal echogenicity, and the spleen was again mildly enlarged. So 8 weeks after discharge, he saw hematology, and these are the labs that were obtained the day of his visit. So his CBC still shows pancytopenia, which is persistent. His urinalysis again shows some trace blood and no RBC. His folate and vitamin B12 levels were normal, and hemolysis panel was obtained, which showed quite significantly elevated LDH. It was 1342, and once we had this abnormal value, we looked back, and then he had pretty significantly elevated LDH even about 20 months ago. He had very low haptoglobin. We do not have any previous haptoglobins available. His reticulocyte counts were very high. The percentage of reticulocyte count was normal previously, but we do not have previous counts. And his bilirubin continued to be elevated with predominance of indirect hyperbilirubin. So this slide is a summary slide for all my previous slides almost. And these were the major things that were taken into consideration during that hematology visit. So this is a cross-section of the liver. This is just maybe not an anatomically correct diagram, but it showed some thrombosis in his portal vein. And we also know that he had some thrombosis in his central vein. We have evidence of intravascular hemolysis, as I showed in the previous slide. And he has some abnormal density in his kidney, abnormal signal in his kidney of uncertain etiology, but most likely some deposition. And other things that were taken into consideration in that hematology visit are, so the degree of pancytopenia was thought to be disproportionate to the degree of alcohol consumption. So all the previous times he was in the hospital and his labs were drawn, every time his pancytopenia was attributed to his alcohol. But this was the first time that it was thought that the degree of pancytopenia is disproportionate to how much alcohol he was drinking. So he was drinking just a couple of beers on the weekend for the past 1.5 years when he came to see hematology. So he had some splenomegaly on all the prior imaging that we obtained. So the splenomegaly may in part explain his pancytopenia, but it's not enough for a complete explanation. And also, interestingly, all the previous imaging studies are negative for cirrhosis. So putting everything into consideration, is it PNH? Was the burning question from that office visit. So in order to test for PNH, we sent some flow cytometry, and JAK2 mutation and calreticulin gene mutations were tested. The reason for testing will be clear in subsequent slides. So voila, he did come back positive for PNH with loss of GPI antigen. This name is too big for me to pronounce. So GPI was found to be absent in 3 cell lines: monocytes, granulocytes, and erythrocytes, using 2 different flow cytometry techniques, so FLAIR and the CD markers. So in summary, he was found to have diminished GPI in 3 different cell lines using 2 different flow techniques, which is diagnostic for PNH. And the testing for JAK2 and calreticulin gene mutation came back to be negative. So since we nailed the diagnosis of PNH, he was started on ravulizumab, which is a complement protein 5 inhibitor. Since PNH is a complement-mediated disease, this treatment makes logical sense. And he was also started on meningococcal vaccination series and penicillin prophylaxis because ravulizumab blocks complement, and complement is how meningococci are killed in the body. So he was started on these. And for the hepatic vein thrombosis, he was started on apixaban for possible Budd-Chiari syndrome. So at this point, I want to talk a little bit about why I decided to give this talk the topic, why I decided the topic Prelude to PNH, because I thought that the diagnosis in this case was made in such a beautiful manner and the events unfolded so beautifully that I thought that the events leading to the diagnosis deserved a special name. So Prelude is an opening to a musical performance. So the manner in which the diagnosis was pursued and the final diagnosis was made is no less beautiful than the opening piece to a musical performance, thus the name. So treatment response. So he was very recently started on ravulizumab, and these are the labs obtained about 3 weeks after he was started on the treatment. So it still shows some persistent pancytopenia. The bilirubin is maybe slightly, maybe a tiny bit. I'm sorry for the interruption. So the bilirubin was elevated, but maybe slightly better than his previous bilirubin. We don't have the fractionated bilirubin. And his LDH, however, came down back pretty, it decreased quite a bit from over 1,000 to 383. So he seems to be heading in the right direction after he received the treatment, but how he tolerates the treatment remains to be seen. So with this, I would like to end my presentation. Thank you everyone for listening. Thank you so much, Dr. Sbenghe, for helping me prepare these slides, and I thank you for your precious feedback and comments. And I would also like to thank Dr. Quidis, who thought that the case is interesting, and he directed me to Dr. Sbenghe. And also, I'd like to thank my program for giving me this opportunity to present this with you, to share this with you. And with this, I would like to stop sharing, and I would like to hand over the screen to Dr. Sbenghe.
Thank you, Dr. Kharel, for your beautiful presentation. I would like to start by giving the patient a little bit of credit. He told me when I first met him that he actually stopped drinking 3 months before his visit with me. This is a young gentleman, and he has a great performance status, and he's actually working 2 jobs. So he's very active, and when I saw him initially, he was already overwhelmed by the amount of testing he was having, but he was very compliant. He was ready to do everything we asked him to do to figure out what was going on. He was puzzled that nobody could tell him what's going on with his liver, what's going on with his blood counts. When I saw him, I told him, I'm going to look for this very rare disease. It's called PNH. I mean, I haven't seen any. Just to use a hematology saying, there are more doctors looking for it than patients with the disease. I have been looking in many patients for PNH, especially in patients with intra-abdominal thrombosis. I haven't found any till this point. The clinical pictures was quite concerning for PNH because of his laboratory tests, because of his imaging, including abnormal MRF, his kidneys suggestive of actually iron deposition, urine, which was showing blood without actually RBCs, the hemolysis, the thrombosis. So there were overwhelming findings, for this disease, but because it's so rare, you're not really optimistic about, diagnosing it, but it's still important for everybody to think about it and be persistent and look for it, because this is a life-threatening condition, and people can have a reasonable quality of life and lifespan if you treat these appropriately. So we all probably remember from medical school the complement pathway, which is it's very complicated. The end point of the complement pathway is the development of the membrane attack complex, which pretty much perforates the membrane most of the time of foreign microorganisms like bacteria, but also some host cells. So let's say this is a microorganism, a bacteria, this is an antigen, the IgG, which recognize the antigen. And the complement pathway starts with the C1 complex and builds up till at the end you have the membrane attack complex, which is made from C5b, C6, C7, C8, and C9. So along the way, you have classic pathway and alternative pathway. Very important, you have 2 factors here, factor B and factor D, which can have treatment implications. And where the CD55 and CD59 play a role, CD55 plays a role in preventing the development of C3 convertase on the classic pathway or on the alternative pathway. CD59 is more downstream and actually prevents the formation of the membrane attack complex because it prevents the polymerization of C9. So a little bit of history regarding the complement pathway. In 1888, George Nuttall found that sheep blood serum had mild killing activity against the bacterium that causes anthrax, property which was lost by heating the serum. In 1891, Hans Ernst and August Buchner named the killing property alexin, which means to ward off in Greek. In 1899, Paul Ehrlich renamed the heat-sensitive component complement as part of his larger theory of the immune system. So a little bit of background regarding PNH. So PNH is a complement-driven hemolytic anemia, which results from the clonal expansion of stem cells harboring a somatic mutation, PIGA, which results in deficiency of GPI anchors. The absence of CD55 decay activating factors and CD59, the MAC inhibitor protein, which are GPI anchor complement regulators, leads to complement-driven erythrocytes lysis and the marked predisposition for venous and arterial thrombosis. The presence of this mutation, however, meaning the PIGA mutation, is not enough to promote and maintain the disease. So usually other stem cell abnormalities are necessary, even if we detect them or not, in order to promote and maintain the PNH clone. So it happens that many patients will have a pre-existing acquired aplastic anemia. They have an autoimmune condition which confers survival advantage to the PNH clone. Other patients will have coexistence of JAK2 or calreticulin mutation without even acquired aplastic anemia. And apparently the presence of these stem cell abnormalities contribute to the clonal persistence of the PNH cells. These days, because of the advances in treatment, the current life expectancy of PNH patients is actually similar to the age match controls. So this is a slide from Mayo Clinic looking at the red cells. This is how a normal red cell will look like. This is the GPI, and this is the CD5 and CD55 and CD59, which are pretty much the protectors of our cells from the complement pathway. So if you miss this GPI, the anchor proteins, then the CD55 and CD59 will not be expressed as protectors of the complement attack on the membrane, and they will be rather internalized. So what are the main clinical manifestations of PNH? Hemolysis, thrombosis, cytopenia, and less likely to be very apparent. Some people will have smooth muscle dystonia, and they can report neurologic findings consistent with TIA. So the hemolysis, we all know what the markers of hemolysis are, and they were presented already in the case presentation. The hemolysis is intravascular and also extravascular. Why is this important is because most of the treatments available are actually able to control the intravascular hemolysis. The extravascular hemolysis can persist despite therapy. And this is due to the accumulation of C3, on the red cells. And interestingly, in time, these patients can develop a direct Coombs, which becomes positive for C3b. And we'll discuss why this happens. So the thrombosis is more common in patients who have a large PNH clone, more than 50% of the PNH granulocytes. Our patient had a very large PNH clone. It was around 80%. Before 2007, which was the year when eculizumab was approved, the thrombosis was the leading cause of death in PNH patients. The thrombosis is predominantly venous, but arterial thrombosis is also reported. The abdominal veins are the most common sites, like our patient. Other common venous sites include cerebral and dermal vein thrombosis. We have also to be aware of the possibility of microvascular thrombosis. And looking back to the abdominal findings on the imaging of this patient, my suspicion is that his thickening of the colon and his GI bleeding was probably secondary to microvascular thrombosis in his colon. So sometimes we do not see large venous thrombus, but this patient can have microvascular thrombosis. The mechanism of thrombosis is multifactorial, but is felt to be mostly complement mediated. So cytopenia, it's also a common manifestation in PNH. a PNH clone may coexist, as I discussed, with other stem cell disorders. And many times we find it associated with acquired aplastic anemia. Sometimes we can even find a myelodysplastic syndrome in these patients. The presence, however, of a PNH clone almost always rules out inherited forms of aplastic anemia, like Fanconi or dyskeratosis congenita. So why this is important, sometimes the first presentation of a patient would be aplastic anemia. And if this is the case, especially in a young person, the thought process is that this patient might have some sort of inherited form of aplastic anemia, and people get tested for. But we should always keep in mind in patients with findings of aplastic anemia, the importance of testing for PNH, because the presence of a PNH clone pretty much rules out inherited forms of aplastic anemia. If the PNH coexists with aplastic anemia, then the treatment focus is actually on aplastic anemia. And these patients require evaluation for allogeneic bone marrow transplant. Some patients with aplastic anemia, especially if they have a small PNH clone, they do not require treatment for PNH in particular. However, there are patients who have a symptomatic PNH clone, and in those cases, the eculizumab is being used as a bridging therapy to allogeneic bone marrow transplant if they have a symptomatic PNH clone. So as we discussed, there are other manifestations that they are not as striking, and people might not remember to look for them. One of them is smooth muscle dystonia. People might complain that they cannot swallow. They say, I can't swallow, or they can have musculoskeletal pain. And this is due to chelation of nitric oxide because of ongoing hemolysis. They can also have TIA, also secondary to transient vasoconstriction due to chelation of nitric oxide. So the diagnosis was already discussed. I will just keep it simple. It's flow cytometry. I will not go into the details how the flow cytometry is done. And the flow cytometry, we show the absence of CD55 and CD59. And this is done on 3 series, on red cells, granulocytes, and monocytes. It's more likely to find it on granulocytes and monocytes, mostly because of the hemolysis process. So what is the treatment for PNH? And first of all, what are the indications for therapy? Not everybody with PNH requires immediate initiation of treatment. So the indications are thrombosis, which our patient had, severe anemia, he did not have severe anemia, or other PNH symptoms, chronic fatigue, pain, dyspnea. The treatment, the current treatment that we have available in PNH targets C5. We have 2 drugs. The first drug, which was approved in 2007, is eculizumab, and the second one is ravulizumab. Ravulizumab is the preferred drug for different reasons. One of them is cheaper. The second one is more effective, and I will tell you in what way. And secondly, is more convenient to be administered. Eculizumab is given once a week for 4 weeks, and with the 5th week, you start a maintenance treatment with the drug given every 2 weeks. Ravulizumab is given 2 weeks for 2 doses, and then is given every 2 months, so it's more convenient. Not all patients will have complete resolution of the hemolysis. Many patients will have some persistent hemolysis. And this persistent hemolysis is secondary to either pharmacokinetic breakthrough or pharmacodynamic breakthrough. So what is the pharmacokinetic breakthrough and how we deal with that? The pharmacokinetic breakthrough means that in between the doses at eculizumab, the drug level might be low, and patients may experience a rebound of their symptoms. When the patient gets the drug every 2 weeks, usually in about the 10th day after the dose, patient might experience a rebound of their symptoms. The way we deal with that is by either increasing the dose or by giving the drug more frequently. Ravulizumab does not have this problem. So this is one advantage of the ravulizumab. You do not have pharmacokinetic breakthrough. Another problem is the pharmacodynamic breakthrough. And both drugs, with both drugs, we experience the same problem. What this means is that despite having therapeutic levels of the drug, the patient will continue to have hemolysis. And the reason for that is the patient continues to have extravascular hemolysis. And we'll discuss why that happens. So the main side effect for this drug is actually headache. And this is mostly with the first dose, because patients with PNH, because of the chelation of nitric oxide, they will have vasoconstriction. And it's felt that the headache is, after the first dose, is secondary to a rebound vasodilation. Do we use this drug in pregnancy? We use eculizumab in pregnancy. We do not have data with ravulizumab in pregnancy. We might get data at some point, but right now, if you have a pregnant woman with PNH, we use eculizumab. So what about anticoagulation in patients with PNH, patients who have thrombosis? Unfractionated heparin is okay. Low molecular weight heparin is okay. It's felt that the newer anticoagulants, oral anticoagulants might be okay. We do not have data, and we are not going to have data because we don't have enough patients to explore the efficacy. My choice in these patients for apixaban was the convenience. And the question about duration, it is felt that this is provoked a thrombotic event, and the duration of anticoagulation is reasonable to be limited to 3 or 6 months, but this is like expert opinion. Some patients will remain on anticoagulation, maybe a lower dose, thromboprophylaxis. I think in our patient case, I think I'll repeat the abdominal imaging and try to make that call along the way. So as was discussed in the case presentation, because the treatment with C5 inhibitors alters the complement pathway, there is an increased risk of Neisseria infection in these patients. So all patients should be vaccinated against the Neisseria. However, even with vaccination, the risk of Neisseria infection is more than 1,000-fold that of healthy controls, with an absolute risk of about 0.5% per year. The penicillin prophylaxis, it's 500 milligrams twice a day in addition to vaccination. There is no actually guideline regarding the antibiotic prophylaxis in these patients. I remember that when I started antibiotic prophylaxis, I struggled with this. I reach out to infectious diseases, to our pharmacy. I look at the package insert of the drug. So this is expert opinion. The patient is now on 500 milligrams twice a day, and I'm planning to continue that for now. We have to use it for at least 2 weeks if you have to start the treatment before vaccination. There is not wrong to keep the patient on penicillin prophylaxis for longer periods of time. Right now, I do not have personally a plan to stop. I will discuss with the patient, and I think together we can come up with a long-term plan. But for now, the patient will remain on penicillin prophylaxis. So because we still have problems with pharmacodynamic breakthrough hemolysis, and that's because both eculizumab and ravulizumab, they act on the C5. We are looking to develop drugs which are working on the complement pathway upstream, because that will prevent the C3b accumulation on the red cells and extravascular hemolysis. So this is pretty much the principle guiding the development of the new drugs. And these are drugs are hard to say, but they are blocking the complement pathway upstream of C5. So the pegcetacoplan is a C3 inhibitor, and danicopan inhibits the factor D. which if you remember from the first slide, this helps the building of the C3 convertase on the alternative pathway by lysing the factor P, which together with C3P creates the C3 convertase. So there are non-PNH indications for complement inhibition. We as a hematologist, we use them in hemolytic uremic syndrome. It is reported to be used in myasthenia gravis. I do not have any experience with that. So this is a great reference, How I Treat Paroxysmal Nocturnal Hemoglobinuria by Robert Brodsky. It was just published recently in Blood. It's a great review with the case presentations. So if you have any questions.
So Dr. Jackson asks, why do we call it nocturnal?
Well, because people hemolyze and they wake up in the morning and they didn't pee all night. That's my explanation. And then, you know, they have a beer-looking urine in the morning. I mean, it's less likely, you know, that happened during the day. I mean, you just drink more water, you pee more often. So I think it's more likely to be obvious in the morning.
Right, Dr. Sham says acidify overnight, but yes. So, let's see. Dr. Chow says, what is the reason for changes in his kidney?
Yeah, so because of the hemolysis, that hemosideриnuria. Actually, when I came here, I was so insistent in measuring the hemosideриnuria, even in patients with other processes causing intravascular hemolysis, just to prove my hypothesis. And I kept ordering hemosideриnuria. And I remember Dr. Fricke told me when he was our chief of hematopathology, Maria, stop ordering that. It's not going to be done.
So when we treat these patients with complement inhibitors, we reduce the hemolysis, we make the thrombotic complications better, we reduce the risk of thrombotic complications, but the PNH clone doesn't go away. In fact, when you look at the red blood cells, the number positive for absence of CD55 and CD59 might actually go up with treatment. So the treatment in these cases is indefinite, right? And it's an expensive treatment.
Yeah, it is indefinite. My patient, who is 45-year-old, I told him this is not a cure, you know, for your disease. You'll always have it. We treat you to prevent complications and try to give you a good life. The lifespan of these patients, as reported, seems to be similar with the age-matched controls. And then his question was, okay, so how do I get cured from this? So the cure is only allogeneic bone marrow transplant. The question is, you know, given the complications and the high morbidity and mortality of allogeneic bone marrow transplant and having effective drugs in controlling the disease, and people can have a, you know, pretty reasonable life. Is there a role in patients with PNH to just send them for allogeneic bone marrow transplant in the absence of aplastic anemia or other stem cell disorders? I mean, I don't think that we have to rush and do that unless the patient has evidence of other stem cells disorders associated.
So Dr. Sham makes the useful teaching point that in these cases with abnormal blood counts, it's often very useful to check an LDH level. In this case, if he had checked an LDH sooner and it was greater than 1,000, it might have led to different thought and earlier diagnosis potentially.
Well, it was checked, and that was my my
No, you checked it, but it was not checked in the hospital. That's the point he's making.
but it was checked a year. I was a little
Yes,
bit
it was checked. It was checked before about maybe 18 months or so ago, but then it was just an isolated one-time finding of greater than 1,000, and it was never rechecked again until we rechecked at the hematology clinic.
I think many patients, when it was checked like 18 or 20 months ago, there were other liver function test abnormalities. So I think the thought process was that, oh, he has liver disease, he's drinking, so all his enzyme abnormalities are second to his liver disease. But the LDH was increased out of proportion for his AST and ALT. So that was a concern. So
you think the PNH was ongoing for 2 years?
yes. I mean, these liver findings, these are not acute.
Mm-hmm.
So I don't think these are, might be some subacute and chronic, but I don't think these are, just happening overnight. I think things have been happening, for a while.
Yeah. All right. Well, the other saying in the hematology world is once you diagnose PNH, then you're okay to end your career. You're done. It's a once in a lifetime diagnosis. So you've done your one PNH for your career. Dr. Sham says the duration of untreated PNH is remarkable. Yeah. And Dr. Chesson says, why wasn't the HAM test done? Yeah, the HAM test was one of the old ways we used to diagnose this. But the current way of making the diagnosis is, as Maria said, flow cytometry, looking for CD55 and CD59. What was the prognosis prior to the availability of these complement blockers? It was really quite bad, right?
Yeah, I mean, people are dying of thrombosis. So I don't have like a number in my mind, but people would, right now they have pretty much the same lifespan, like age controls, but in the past, people were dying of thrombotic events probably in a few years.
All right. Well, I think we covered most of the issues and questions. Thank you both very much. That was very interesting. Nice presentation. Good topic. Thank you.
Thank you.
Thank you. Have a good day.